afternoon. Welcome to our Session 9 Medi-Cal Academy. Today we're talking about Medi-Cal documentation standards and processes. An important topic, right? Because we have to have the documentation in order to submit that billing to have that reimbursement happen for us, right? So we got to get this part right. And so we're so glad that you're able to join us this afternoon. Many of you have already been with us throughout the duration of this academy, but just so that we're all on the same page around who we are and who's talking to you, CSH is a national nonprofit, and our business is in the space of helping folks connect to housing. So advancing solutions that help elevate any platforms that do that, right, for our most vulnerable community members nationwide. And that can look like nation advocacy work or consulting. That can look like regional work, such as work we're doing right here in California around our Medi-Cal Academy, other policy initiatives and other activities we do in different regions across the country. And we also act as a CDFI, which means we provide actual lending to developers who are develop supportive housing across the country. A little bit about who's talking to you, and then we'll get more specific. So if you haven't met me already, my name is Ambrosia Crump. I use she, her pronouns. I'm with our national consulting team here at CSH, and I'm so happy to join you with my colleagues. I'll turn it over to Cheryl, who you've probably met, but she can say hi and also introduce you to our colleague, Terry.
Hi, everyone. Good to see you again. I'm Cheryl Winter. I use she, her pronouns as well, and I am on our California State Policy team. I'll hand it over to Terry.
Hi, everyone. Glad to be here. I'm your guest presenter, I guess, today. I am the Associate Director in the Ohio office, and I am a licensed social worker. I have worked with agencies that have billed Medicaid, both on the behavioral health side and also with Volunteers of America most recently. We started a Medicaid contract with our family transitional housing and supportive housing programs at Volunteers of America. So I understand the transfer of the culture and the transition and the shift. So I'm here to help you through the documentation pieces of it. Glad to be here.
Thank you so much. And we're so glad to have Terry join our team today. So just so that we all know who's in our space, if you don't mind quickly, maybe dropping in the chat the organization you represent, perhaps your role with the organization, and a little curious about how comfortable you feel with Medi-Cal documentation or the concept of it if you haven't done anything like this before. Maybe on a scale of 1 to 3, we'll pick a number there. So 1, maybe I don't feel comfortable at all. I'm kind of worried about it. Maybe 2, I'm kind of in the middle, or I feel like this is something we can handle. And 3 is like, this is just review for us. We're just checking the boxes to make sure we got it.
Yep,
and that we know what's happening. That. Yeah, see where everybody is. Taylor's already all the way at 5. He's teaching us.
Mm-hmm.
Oh, it sounds like a lot of folks around 2 and 3. Welcome.
Great.
Welcome, Melissa. Welcome, Cecilia. So just a review of the Medi-Cal Academy, what we've been working on. You can see we've hosted a lot of sessions. You may or may have not been part of that, or maybe another team member from your organization may have attended some of those sessions. Along with today's session, that extranet link that we provided will give you access to previously recorded sessions and the relevant materials from those too. If you're like, wait, I missed all this stuff, I'm at the end of this thing. So don't worry, that link will take you back to what we've already done thus far if you need to go back and double back. But today, we're talking about Medi-Cal documentation standards and processes. The audience, hopefully you are this audience, if you're a provider, right? Or you're someone that supervises providers or direct service staff, whether you're with the county or with an organization that's serving the folks that we're looking to target with this service here in Medi-Cal. Next session that we're hosting on the 18th is our EHR Elements. That's a great session to maybe come to if you're looking at how can I try to streamline the process if I'm going to onboard an EHR or electronic health record system. And so what we may want to bring to that are some of the data elements that we're going to track, especially if you have different funding sources that we're going to continue to maintain, to see how we can best integrate what we're already doing with what maybe we need to start doing in a new system. So that we're looking forward to seeing you guys there. If it makes sense, if you're not there yet with having an EHR, to join us in exploring that. Welcome, welcome everyone. So today, what are we going to talk about? First, we're going to look at understanding what the golden thread is. If you haven't heard of this term yet, we're going to define it, and we're going to talk about what the documentation flow should look like for that. We'll be talking about some key elements that a billable know or billable, any documentation really throughout that golden thread process should include that will lead to hopefully seeing approvals, right? Because we'll be meeting those standards as requested either by managed care plans or by the state, and certainly best practices for Medicaid or Medi-Cal. We'll be talking about how best to document what's happening in those experiences with our clients, with the tenants that we serve. So how to write goals, how to capture the interventions and activities that we're doing with and for people, to tell their story really, but also to talk coherently and consistently throughout our documentation about what we're doing for folks so that people can pick it up and understand what happened and what to do next. We'll be talking about what Terry mentioned earlier, that there may be this may be a transition for your organization. Sounds like VOA had a transition. And so what that may look like, best practices to support transition in your organization if billing is new for you, documenting in this way is new for you, and how to supervise folks through that process. And then last but certainly not least, we'll be talking about your internal monitoring process for those elements to making sure that we're doing what we need to do documentation wise, how to do quality review to support providing our best service for our clients, and also making sure that we're not potentially losing funding or putting ourselves at risk if we can protect our organization as well. So both sides of that. We can go to the next slide here. And I will be turning it over to Cheryl to talk about why documentation is important.
Thanks, Ambrosia. So for those of you that were on our last session about policies and procedures, this is a good complement to it, which is why we put them back to back, because oftentimes when we think about documentation, we're thinking about compliance to help us to get paid. And we do want to comply with what's required in our contracts with managed care organizations, with county health service departments, and with Medi-Cal and federal Medicaid. But ultimately, we are doing this because we want to best serve the tenants and clients who are experiencing homelessness and transitioning into housing. So we're going to talk about ways that you can tailor your documentation, assessments, service plans to still meet those requirements that are keep you compliant with what funders are looking for, but also that are serving the tenants and reducing burden on staff. So our first topic that we're going to cover briefly is the golden thread. This is a term that has been used a lot in Medicaid speak. And so across many different Medicaid federal programs, they use this term, the golden thread, when talking about the role that documentation plays in following an entire client's or patient's medical journey. And that in order for services to be reimbursed, the payer needs to be able to see everything in the documentation from the client's needs and strengths that are assessed initially at intake to how those are turned into goals and action steps and interventions in a service plan that's individualized, how those then are documented in progress notes through service delivery, and then how you are documenting the progress of what is changing, what skills are being built, how are you supporting the tenant to achieve those goals so that when you come up for time to reassess, you have a documentation thread across that is this golden thread that that makes it easier for you to then plan next steps. So when we're talking about these specific tasks or forms, the assessment that often is accompanied, happens during intake or shortly after intake, your individualized services plan, your progress notes or case notes. Those are things that most of you said during your Medi-Cal Academy application that you already have some sort of process around that. So this shouldn't be new, but what might be new, and we've put that little healthcare symbol, is this requirement that it be able to be threaded through, and that someone could pick up a progress note and from that progress note be able to look at the service plan and say, yep, this activity done on this day falls within the goals that were set and it's linked back to the tenant's needs. So this may be new. Something else that might be new is that there is a requirement for quality reviews and ensuring that your progress notes, what is included in your individualized service plans and your assessments, then pull data elements into what goes into your invoices for reimbursement. And so there is going to be a need for your agency to have some sort of internal review to ensure that you have all of those elements being entered in a timely way that meets the documentation requirements set out by Federal Center for Medicare and Medicaid Services, CMS, and what's required by the Department of Healthcare Services for the state of California. And we'll get into those requirements just after this section. Okay, we talked a bit about this when covering the section on compliance with managed care plans. This is compliance and chart review in documentation. They go hand in hand. And so you're going to want to be reviewing the tools and templates that we shared in the policy and procedures folder last week, because there is a sample documentation policy and procedure that might help you in thinking about how do you start doing your internal quality review of your documentation to understand, you know, does every client have an assessment, have a complete service plan, and have regular, updated, timely, accurate progress notes meeting this? And if not, you can start to develop a plan for how you can get there. In talking with some COCs across the state, it's very common for service plans to be required, but there may not have always been someone checking in HMIS that things get entered in or uploaded or updated as frequently as might be required by managed care plans. So this might be a new process in terms of how often you are updating these assessments and service plans. So just a review that, you know, oftentimes when we think about documentation, specifically service plans and progress notes, we're thinking about the case manager being the primary author. This changes. I know it's best practice and many homeless service providers already include the tenant. There's going to be more of an emphasis now on including the tenant's voice, and in your service plans outlining which responsibilities and activities will be completed by the tenant and which interventions and services and supports are going to be completed by staff, and when are those things done together. And you're going to want to outline timelines. So this again is something that can be supported by your supervisors, reviewed by quality assurance staff, and then there may be times where funders want to see all of the, you know, documentation, progress notes, service plans of a particular member. So you want to make sure that you have everything filed away in a way that you can pull it if needed and requested by a funder. All right. Feel free to use the chat to enter in any questions. I went through that section pretty quickly because we want to get right to what are the standards and processes for documentation. But just do want to remind you that this language that we're going to be using today is about Medicaid federal requirements or best practices. And for some of you who have contracts with managed care plans, those managed care plans may be planning to do audits or may not be, and may be requiring all of these elements or may not be, because right now these housing related community supports are voluntary. When we can, we will specify today what are the specific elements that are outlined right now required by the Department of Healthcare Services? And what are some things that are recommended best practice to help you to bring your agency up to speed with Medi-Cal and Medicaid requirements if this were to become a benefit in future years? Okay. With that, I'll hand it over to Terry to get us started on talking about documenting services.
Thank you. So I am not totally familiar with what is required in California or what might be. So as Cheryl said, I'm going to be talking about best practice and what is required on the federal level. So I think that if you look at this and have your sights set on best practice, then you'll definitely be in good shape. So the first thing we're going to talk about is documenting the need for medically necessary services. Cheryl mentioned that in her intro when she talked about the golden thread. You're going to hear a little bit more about that. And I also want to say, after my section, Ambrosia is going to talk about some actual examples. So we're not just talking theoretical. We are talking theoretical, but not just theoretical. You will get some practical implementation. I know that when the VOA staff were going through this process, we had to follow all of the federal requirements very strictly. And it was really important for us to get that practical implementation training. So we're going to hopefully set some examples for you and have some good handouts. In order to look at what medical necessity means, I always think it's important for us to think about when we go to our primary care doctor. We have insurance, and that insurance has to be authorized for it to be paid for whatever it is we're going to the doctor to see. And it's the same way. It may not be physical health, it's behavioral health, but it is in that same vein that Medicaid or Medi-Cal is an insurance, and things do have to revert back to what made this person eligible for this service in the first place. And hopefully, if this does become a benefit and you have your housing support plan and community support plans, you'll be really ready to go with what is needed. So as the golden thread, the first thing is that the need for the service is based on the assessment, whether it's a diagnostic assessment, a functional assessment, a vulnerability assessment, whatever begins the process, it begins with that assessment. What are the needs of the client, and what are the goals based on those needs? So again, you see that connection, you see that golden thread. So you have a needs assessment, and then you have goals where there's a clear connection to what that assessment looks like. And we also want to make sure this is a partnership. You're going to hear me say a lot that we're partnering with our clients and we're partnering with our tenants to make sure that their voice is being heard. And we don't want to lose sight of that when we're talking about what is required and how you write a progress note, because we're hoping that in this, and it was true for Volunteers of America, we did become a better program. Despite the fact that there was a lot of requirements to follow, we also were able to have a higher quality program, and we were able to hire one additional staff that helped us with the children of the families that we serve. So we really don't want to lose sight of the impact and the quality of care within this need to comply with the documentation requirements. So as the case manager, care coordinator, whatever your title is, it's important when you write the note. So we have the assessment, we have the service plan goals, and then we have the interventions that we're going to talk about in a minute. And that's where you look at what are we doing, how are we partnering with this client to further the goals that they have on their plan. The person, whether it's internal or external, we're going to talk about internal monitoring as well. Whether it's internal or external, the person looking at the notes, you want them to hear the story. You want them to know, oh, I get it. This is what the assessment said. oh, and this is what the client's goals are, and now I get it, that I'm reading these notes, the service intervention you're providing makes total sense based on all of that. That's what you want the reader to know and to look at. We know that there's crises that happen. We know our clients get distracted and we get distracted. We're not perfect. Not everything is going to be a formal, let's review the goals. And that's okay. That happens. But I think we always need to keep our eye on what progress is being made and how do we help our clients get there. And then you want to look at the type and the frequency. What complex needs does this particular person have? And how is it related to the frequency of how often I need to be with them and for how long each time? You want to make sure, and we'll talk about that, you want to make sure that's justified. Is the needs of this person very complex and challenging? We need to be there twice a week for 45 minutes, or do we need to only be there every other week for a half an hour or an hour? So you want it to be appropriate to the needs of that person and the goals of that person, and seeing how complex and challenging, what barriers they have, what strengths they have, and have those interventions accordingly, which you probably already do. We all see our clients based on their needs and their goals, but this needs to also be something that we can read in the chart and make sense to the person reading it, and they can follow all of that. And again, as Cheryl said, please ask any questions possible. I know with Volunteers of America, this was very new for the staff there, and that we had a lot of training around it. So anything that doesn't make sense, or you really want to ask about, or anything, as Cheryl said in the chat earlier, those of you who are really, really good at it, you want to share some tips, I'm sure everyone would be willing and interested to hear that. Okay, so specific progress notes. So this is what we call the technical elements of a progress note. So that is different than the narrative or the quality of the note. When we're doing internal reviews, you could have a checklist of this, because these are things that are either there or not there, and you can check it very easily. The green, as you can see, is not required right now, but it is best practice. Also, it makes it much easier for the person coming in to audit or to monitor your charts. And we really want to make it as easy as possible for those people who are coming in and reading our charts and auditing us. So you want to have the date of entry. When are you writing this note? Mostly it should be within 24 to 48 hours of the time that you actually have the service provided. You want the date of the service. You could have the start and end times and the length of service in minutes. When we were at Volunteers of America, we were billing per unit. So we had to have that. That was a requirement. And I had both because, again, I wanted to make it really easy. I didn't want our auditor to have to get out his little calculator and figure out how many minutes this person was seen and only having the start and end time. So we had the start and end time, and we had the minutes. The location, were you in their apartment? Were you in the community? Was it phone? So you need to specify that, client name and ID, however you identify that client within your own agency. And then within your note, we're gonna talk later about the actual narrative of the note. But within the note, you want to make sure that you have clear what is the progress of this client, any changes, good or bad, back and forth. What is the client response? You want, again, that service to be linked back to the goals, and you want next steps. Doesn't necessarily have to be next appointment time. Sometimes our clients are not really good at those structured appointments, but some next steps. And then your signature needs to be authenticated that you were the service provider, and you need to sign it and date it. And you could put the title. We did at Volunteers of America because there were tiered rates based on the degree of the staff person. So if they were a bachelor's degree or if they were a mental health professional, whatever they were, So we needed to have that in there. Also, one thing I did that I think was really helpful at Volunteers of America that might be helpful for you is I went through all of these requirements and I revised our progress note to have a space for every single thing that was required. So as staff were going through and writing, there would be a blank space if they didn't catch something. So it triggered them. Oh yeah, I got to write client response. It's in the note and there's a space for it. And that was helpful. Okay, next slide. Thanks. So as I mentioned, it's a medical record. We're going to talk about the progress note narrative, but you need to sign it whether you have electronic health record or a paper record. It needs to be signed and dated. That it has to be, of course, legible. If you have an electronic health record, that wouldn't be a problem. I'm actually just remembering that I had to have some staff actually type notes because it was really bad. I worked at Volunteers of America 10 or so years ago, and we had only paper charts, and it was really, again, you don't want to make things difficult for people who are monitoring your records. If you have a staff person who can't write, then things need to be typed so it's easy to read, and making sure all those are signed. Next slide. Okay, best practices. Oops. So this is assessment and service plan best practice elements. So it's important that, again, we're going to go through some of this. So you have the assessment, the functional criteria that is provided by your managed care plan. They should provide that with you. I understand, unfortunately, there's many managed care plans and you have to deal with more than one, which is, I'm sure, frustrating, but they should be providing that to you. It, again, has the needs that need to be addressed and the goals based on those needs. We want to make sure we hear the tenant's voice or the client's voice. We work with people who have been homeless, who have been in and out of jail, in and out of prison, in and out of hospitals. Their voice is not been heard. So it's really empowering and powerful for us to partner with our clients and to make sure that it's their goal. If you just think about yourself, and if someone would come in and say, okay, well, we're going to work on this, this, and this, and this is what's going to be happening in the first 30 days, and this is going to happen here. And I'm a social worker, and we still do that to people, and I don't quite know why. But if you put yourself in that place and think, why would I listen to you? And have goals based on what you're telling me. So we want the buy-in for the client. We want it to be as impactful as possible. We want it to be quality. And we want the partnership with the client. We want to work with them to say, what are your goals based on your assessment? And they do need to be measurable and clear, and smaller objectives to reach the goal. Some of our clients have pretty lofty goals. They might want to get a better job. They might want to get custody of children. They might want to get visitation of children. There's a lot of things that our clients want to do, and it could be overwhelming. So we want to make sure that we have smaller objectives to help them reach that goal. The strengths of the client, it's the best practice to have that in your service plan or support plan. I think it's called housing support plan. And mostly the strengths that are actually tied to the goal. So what is it that will help this person to obtain visitation again with their children? And what strengths do they have? Are they highly motivated? Do they want to take a parenting class? Are they willing to have some negotiation with whoever it is they need to? So write those strengths in that will help, that are linked to that goal. You want to have timelines. That there may be requirements with those timelines. I know in Ohio with Medicaid, it was every 6 months, and I think now it's only every year. But you want to make sure you know what the timelines are for those goals, and to update those goals, and to update the objectives as well. And you want them to make sense. Your service plan or housing support plan should be something that is a document that is usable, that you look at with your clients, that you say, how are we doing? How are you doing? Is this a goal that you still want to work on? Let's look at this and look at it as a working, helpful document, not as something that you just do to check a box that you're compliant. Roles and responsibilities, what is the client going to do? And maybe what are you going to do as the care coordinator? Is there some research that you said you would look up? What is, are you going to remind the client to do some certain things? So what is it that are the roles and responsibilities? The service type and amount, that's where many times, especially in Ohio, they called the service plan the prescription for the service. So it had on there what we were going to do and the goals and how often it was going to be done. So were we going to meet with this client once a week, twice a week, for an hour? And that was like the stepping stone or the guide stone for how often we saw them was in that service plan. And then you want to note your progress and you want to update it. So how are we doing on this goal? How close are we to you getting visitation again? What went wrong? What should we concentrate on now that we're this far along or 3 months in? What do you want to change and what do you want to keep the same? Again, that's a partnership. That update of that service plan is a partnership with the client. Okay, next slide. So we have goals on the service plan and we have the intervention. The goal is what is in the client's voice, in their what they want to achieve in their words. What is it do they want to achieve? What is something that they were always hoping that they could do? What are their dreams and goals and values? That's what the goal is. Your part is the intervention. How am I partnering with this person to move them forward on this goal that they want to achieve? And I think a lot of times I should speak for myself, back when I was a case manager, sometimes I got a little judgy about what clients' goals were and what I thought they should be and shouldn't be. And it's really about them and what they can do. So even if we may not agree with the goal, or we may think they should work on something else, if this is what they want to work on, then our role is to, how are we going to help them get there? So you see the arrow on to that target. How are we going to get them to that target, that what they want to work on and what they want to do, what their goal is? They may come to the decision that it's not the goal they really did want to work on, but it's theirs, and it's important that we help lead them or guide them toward that goal with our intervention. Okay, next slide. So Cheryl, anything you want to point out? I know you're chatting. Anything you want to point out, please do.
Yeah, I just wanted to say that piece around, supporting any goal that the client has, the housing related community supports, housing navigation and transition services, and housing and tenancy sustaining services have a list of allowable activities that when you sign up with a managed care plan and have a contract with them, they are expecting you to provide any of those activities that a client might need, and they are housing related. So if a client has a goal that is not housing related, but something that could help them to sustain their housing, your role is really that coordination role. And there is a piece in the community supports provider guidance that the policy guide that says that community supports providers should be coordinating with other providers in the community and with the enhanced care management provider. So if there's something that's outside of that list of contracted activities and you don't provide other types of supports in-house that are related to a client's goal, you still can write down that goal, and then under the activities and interventions, your role is then helping to connect them to someone in the community or to enhanced care management provider that can help them with that goal. So you still want to honor whatever goals it is that the client might have, even if they may not feel like they directly align or fall under those housing related activities, because you can then show the progress on how you've connected them, and that care coordination piece is considered a part of the contract.
Great, great, thank you. And I know with the program that I run right now for CSH, which is a statewide supportive housing program working with individuals leaving state prison, one of the things that we have to do is connect their goals back to decreased recidivism and maintaining their housing. And so, but we still want it to be their goal, as Cheryl said. So we ask questions like, what will help you maintain housing? How is it important to you to not go back to jail? Or prison? What can you do that will help you not go back? So it's still, even though it's within the activity that, or the goal that we want them to focus on, there's still a lot of room for their voice in that. So writing the narrative, again, we want to focus on the services related to the goals and make sure that we have some progress or lack of progress somehow related to that. Again, when we did the Volunteers of America, when we revised the progress note, like I said, I had a space for everything that was required. So the service plan goal, which goal was it that they were addressing? You wrote it in that note, and that helped. You want to relate it, again, that golden thread back to the needs assessment, back to the person-centered plan, back to those goals. It's important that we learn how to write a note. Unfortunately, with Volunteers of America, it was a huge culture shift on how to write notes. And we had a lot of the he said, she said, and then I did this, and then the client did that. And there was a lot of detail, but not a lot of substance. So you want to get away from those kinds of notes and focus more on the strategic intervention that happens. And that sometimes is a transition, and you need to help staff with that. I did have to provide a lot of training and education, and I read a lot of notes to help staff come up with that. It was a big change for them to focus on that big picture. And it made them better case managers when they were focusing on that bigger picture and the goals. You want to focus on the facts. We always say when you're writing a note, it's really important that you imagine your client reading it, or imagine it being spoken in a court of law, because both can happen. Clients can request records, they can look at their records, they can read their notes. So you need to make sure that it's factual. You're not being opinionated, but you're stating the facts. There's a big difference if someone is laying on the couch, and actually, unfortunately, this happened when I was reading a note. The staff person described this mother as lazy, and really, that didn't tell us anything. But what should have happened was, what did this person observe when she walked into the apartment? That would have been much more helpful, and would have helped the reader learn exactly what was happening. But the opinion of the mother was lazy didn't get very far, and it wasn't helpful. So you want to avoid that at all costs. So you want to be as objective as possible, but we also say you could use SOAP, which is subjective, objective, assessment, and plan. And where the subjective, what that means is saying it in the client's words. What is the client experiencing right now? Your part is to be objective, not opinionated, but objective, and state the facts. And you want to always continue to assess what is happening. So if you walk into someone's apartment and the mother's on the couch and the kid is running all over the place and crying, you want to assess what's happening at that moment as best you can. And then you want to plan. Let's make a plan for what we can do to help with this situation. And again, partner with the client to do that. You want to demonstrate sufficient duration, whether you're a per unit or per member per month billing. You want to make sure that if you spend an hour and a half with someone, and a managed care entity is asking you, why did you spend this hour and a half? You can go to your notes. Somebody can go to your notes and they can understand why you did that. Or if you see someone twice a week for 3 months, they should be able to go back to the service plan and look to say, oh, yes, that was planned. They said they were going to see the client twice a week for 3 months. And then again, include the client's response. Is the client engaged? Are they distracted? Are they making progress? Are they caring about this goal? And do you need to revise that goal and then plan for the next step? Okay, next slide, thanks. So you can sometimes, depends on if you have a laptop, if you have electronic health records or not, you can sometimes, at the same time that you're meeting with the client, not every client, but you can begin to write your note when you're with the client. There were some clients I could do that with and some we couldn't do that with. But it was really helpful because if you see 3 or 4 or 5 clients in a day, you're never going to remember everything that everyone said. It's just not possible. So it's important that you write down what's happening so that you can remind yourself, either in total, so you're totally done with the intervention and the note when you leave the client's apartment or when they leave your office, or at least you have it started with the note. It's also important, as I said, remember, it's important to partner. So you can use some of these questions to help include the client's voice in your note writing. And some of these questions are here for you. In terms of other goals, are there other goals you'd like to see? Is this goal working for you? Is there anything else I can do? How are you thinking this is going? Some of those really direct questions are helpful and may be very different for clients to hear. They may not be used to it. So if you ask and they don't know how to answer, be patient and help them with that. They're probably not used to people partnering with them and wanting to hear their voice. So these are ways that you can include their voice if you want some examples and questions. So when you're goal setting with clients, again, some practical words for you to use that might help. You know, what is it? What does the client want to increase, or what does the client want to decrease? Do they want to improve something? What do they want to achieve? So these are action-oriented words that will help you and will help the client in your goal setting. I know the program that I run with CSH, people who are leaving prison, they have been in prison, some for maybe 6 or 7 years, some for 20. So when we're talking about goal setting, they really don't know. They've just lived day to day for the last however many years. So when we use these words, it helps us, but it also helps them to think about what do they want to do? What do they want to improve or decrease or achieve? So it doesn't only help you in managing it, it also helps them. And I think we have handouts on this. Good. That will help.
Yep, I just put it in the chat and it's also
Okay.
in the folder for session 9.
Great. And then for keywords for interventions, there's a lot up here. It's hard to see, but I think we have a handout for this too. So again, just helpful hints when you're trying to think of, I mentioned earlier, we don't want the detail of what happened in your session or in the apartment. He said this and they said this, and then somebody knocked on the door. And again, that's a lot of detail, but not a lot of substance. So we want the substance, we want the strategy, we want the big picture. And if you look at this and these words should be helpful to you as you're writing your notes and trying to have that strategic perspective. Could be very different for your staff to have that strategic perspective and that big picture of the progress and the goals and how they're doing. As I said, with Volunteers of America, it was a big transition, but it really improved the quality of our programming with our families. And then I mentioned this already, but just again, another word about it. It is important if somebody is reading your record, it's important that how much time you are spending with someone is clear. Are they continuing to be distracted? Are their reading skills really poor? If you're filling out a housing application and it should take half an hour and it takes 2.5 hours, why is that? Is it very foreign to them? Are they poor in writing and reading? So just making sure that you document all of that. I know it happens. We know all of these things happen when you're working with clients and when you're doing things with clients, but it's important that you document why that is so that anyone reading it can understand, oh, that's why.
Terry, I'll add here.
Yeah.
And the evidence-based practice session number 3, we talked about, what best practices say for caseload sizes and how so many homeless service providers in California, the caseloads, because of limited funding for services, are much higher than what the evidence base says. And now with this opportunity of additional funding coming in from community supports, if you are documenting how much time your case managers are having to spend with each person and relating that back to the assessment, and because the managed care plans are now sharing with you diagnoses and functional criteria and other things related to medical necessity, this is an opportunity for you to then, when you're doing, a year review of the people served, the amount of staff time spent across, you'll be able to then advocate for smaller caseload sizes, saying our case managers are spending, X amount of hours with people that have this diagnosis and this need. And we really need to return to the evidence-based practice of having a 1 to 10 or a 1 to 15 caseload size. The research shows it, and our documentation shows the need for it. So it'll help you to argue for rates that cover those smaller caseload sizes through your own documentation.
Yep. Thank you, Cheryl. That is really important. And, as I said, I know that we do great work with our clients and tenants, but we really need to show the great work that we do. And this is one way that we can do that. And Ambrosia, thanks so much for calling that out. I think, well, do you want to?
Yeah, I was going to say the funder, managed care plan may not understand, the unique work we do when we're working to get folks housed and keep them housed, right? And as you talked about, Terry, sometimes, systems have let folks down, and so they're maybe less hesitant to engage in the way that maybe managed care plans might think is, the speed at which that should happen. And so I think it's important also to just, document that rapport building work you have to do sometimes for weeks or months before we take the next step in obtaining ID or signing a lease, right? And justifying that in that documentation helps that funder who may not be used to this work understand what it might take to actually move through the goals that are identified if they're not accustomed to the work and what it looks like to get it done.
Yeah, thanks for bringing that to the forefront. It will take a long time. Again, we work with people leaving prison. You work with people, I'm sure, who've been homeless on the street. They're not going to come up and trust us in a minute or a month or 6 months sometimes. And being really clear about that. Client is mistrusting, client has been traumatized, has gone through, this cycle of trauma over the last 15 years, and moving slowly, because building rapport is the foundation of how change is made. So making sure that's really, really clear is important. And again, showcasing what it really means to work successfully with the clients that we serve and to make an impact in their lives, making sure that people understand that. Thank you guys for that.
Yeah, and that goes back to the Department of Healthcare Services guidelines of using evidence-based practices. So they literally call out harm reduction and trauma-informed care and motivational interviewing. So you can use that language when you are then advocating for the time spent and why you are taking that time to build rapport.
Yep, great. So one other reason to have good documentation is it does support this continuity of care on several fronts. One, the transition. So just with staff that you have now, supervisors and staff now, this transition, making sure that good documentation is understood. We talked about making sure that the good quality of service that you are already providing is seen and shown, making sure that that happens, and making sure that everyone understands that. We also know that staff turnover happens all the time. People do not stay in case management, care coordination roles. They move on. We know that happens. So if when we have new staff coming in, it's really important that they understand the progress notes and the progress that this client has made. So making sure your documentation is really clear. Again, thinking about the client reading it, but also if you think about when a new staff takes over, you want to make sure they understand. So keeping those things in mind when you're writing your notes will also help you be a little bit more specific and strategic to give the person reading it that story of the client and where the client's been and where the client is going. And then also keeping in mind new staff, and we're going to talk about orientation and training. New staff will need that extra support and extra coaching to help, especially if they've not come from a place that has billed Medicaid or has had these kinds of documentation requirements and guidelines. It's important that they have the support that they need, get them started off on a good foot where they feel confident about what they're doing and how they write a note, give them whatever time that they need and supervision that they need to make sure that they understand how to write a note. This may mean you have to read their notes with them or help them with questions on why isn't this a good note and why is this a good note? So maybe providing some examples, maybe doing some role plays. So really being an active supervisor and a supportive supervisor in helping people get off to the right foot. We don't want staff to go in and make a bunch of mistakes and then have to backpedal and not really have the support or the education or training that they needed in the first place. So we want to try to be as proactive as possible.
Terry, can you set some expectations for teams that are totally new to this? What is a reasonable amount of time as an agency is thinking about updating forms, training staff, supporting staff in the learning curve? Is it months? Is it years? What do you recommend, just so folks don't feel the pressure of it needs to be done yesterday?
Yeah, it does depend on where your staff. So with Volunteers of America, we were, I feel like, starting from ground zero, and it took about a year. And we weren't perfect in a year, but we were at least to the point where we could move forward a little bit more in terms of what actually we needed to get the contract. We didn't get the contract in a year. I think it actually took 2, but it took a year before we felt like we had firm footing. So if you're on your way, it may only take 6 months, but it took us a year, and then it took another year for us to actually get our billing, like get our first billing out.
Thank you. That's really helpful. Just to.
So yeah, we're going to take really just the theoretical and talk through this practically. Like, what does it look like to do the note better and write it to best practice and be objective? So let's look at some examples of objective writing here, right? So someone could write in a note that the apartment was a mess, right? And so what is a mess? What does that mean? Terry said, that really doesn't give us a lot of content or information, and everyone's standards of cleanliness, believe it or not, are different from our own. And so really we want to write what we saw. So when I always think of this, or talked about this before with other direct service providers, I always say your objective writing is what you see and what other people say. Kind of think of the 2 S's, the seeing and what people are saying, or direct quotes from our clients. And so here in this more objective version, we see the writer observed, this is what they saw, right? What actually was happening there. They saw food, garbage, clothing, and papers that were blocking walkways and vents. So this talks about, what maybe some risk were there, right? What are some consequences of what is happening because of the items being left and blocking the vents and walkways, perhaps a safety issue, right, to address. And this other one, we say, hey, someone might have wrote, that client was just out of control and they got kicked out of the store. Part of that could be objective. They might have observed them getting kicked out of the store, but what predicated that, right? What does the quote unquote out of control behavior actually mean? What does someone understand about the actions or the experience for that person and the people around them? So the client was experiencing some active paranoia and they had some persecutory thoughts. I would like them to actually, even if they could, say what the client saw here, said here, right? That would help us to know, how do we know that they had those thoughts or this feeling paranoid? Then they maybe started screaming at other shoppers. So this is what triggered them to be asked to leave the store, right? Security was called and then the client was escorted out. And then we have another one here. It says that the client's doing much better in living indoors. Again, what is better? Who determined that? Did the client, you, and how do we know? And so what leads us to know what much better is? So those quotes, you can see in the camera, much better is. So client is appearing to us calm. They're appearing confident. They appear to be in good health. This is our observation. This is what we see. The client showed the writer how she stores her meds in her weekly pill box. So this is maybe an indication of maybe medication compliance being improved, right? We're asking her how she liked her unit, and guess what? This is what she said to us. We're quoting her. I like this place. I mean, I can't stop smiling. I love it, especially the AC unit. And so, again, objective writing is about really focusing on the facts about what happened and really taking out, our opinion or maybe some judgments that we have, not necessarily negative, just maybe just deep in our own experiences and our own expectations, right? So sometimes when we think about opinion or subjective, we're thinking negative. Some things could be positive, but again, we want to make sure that we're giving good information for a reader to understand and to be able to paint the scene. If you're like a director or screenwriter, right? How does someone know what's happening in the scene? Let's write out that content so someone can pick that up and step into that moment like we did, right? And think about what Terry said, especially, this is a scare, but to think from this perspective that, hey, if someone were to request our records, if they get subpoenaed, or even, I've helped folks like pursuing benefits, guess what? The judge orders the records to justify like functional impairment and medical challenges and mental health challenges. So they're going to ask for case management notes. Is this something that you would want to be read in court? So thinking from that line, purview about how we write our notes and what we might say about the people we serve in that note. We can go to the next slide here. So let's dig deeper into like an example of how this can look across the whole golden thread spectrum here from start to finish, right? So maybe here we're starting with our service plan goal. And so the ECM provider maybe is the one that's helping to identify these needs. It could be you as the provider doing this here while you're writing that service plan goal in the actual service plan. And so we're using the client's words because they are co-writing this with us. They are setting the goal with us. So they said, I don't want to be evicted. I want to stay in my apartment and I want to get along better with my neighbors. So these are we're using their words here, right? And so then based on what they've shared with their goal is our recommendation, we can see here that they need the housing support services because that client is at risk of eviction due to some continued negative interactions with neighbors and some complaints. And so based on that, what are some objectives that maybe we can help co-set with our client, our tenant, based on those two big goals that they have? So these are some things that maybe the client's going to do, right? So they said, hey, I'm going to go to anger. I'm going to engage in some anger management interventions, meaning they may not use the word intervention, but they could say, hey, I might be going to classes. I might be learning some coping skills, right? To learn to communicate better. And I'm going to maybe find some things to do so I don't have too much time on my hands. So I am distracted with activities. And then maybe another goal then after this intervention is, after they've outlined their action, we're going to say, hey, what is our role in this, right? Because this is the part that makes it billable or reimbursable. Otherwise, maybe we have to give the client the money. But we're part of this too, right? So what are we doing in this space? So we are working with our client to model. Maybe we're doing role playing, how to practice talking to the neighbor when something happens, right? Making phone calls with our landlord and just exploring some communication techniques. We may talk about mindfulness interventions. We may talk about anger management to help them manage that anxiety and frustration, right? So this is what we're doing in the intervention or action part, using some of those key terms or words that Terry showed earlier. We can go to the next slide here. So how could a progress note look? So we have our service plan, we set our goals, our objectives, we talked about interventions that both we would do and what we would do, and the goals and the objectives and activities that the client would do. And now this is a note we write after all of that happens, right? So we met with Jane, we discussed her housing issues regarding her potential eviction. The writer offered a non-judgmental support, this is our action, which allowed her to be open and honest. We discussed strategies that she could try to better resolve her conflict with her neighbors so she doesn't get evicted and possibly become homeless again. And so as a result of that, she agreed to attend some anger management sessions, right? So she's gonna find new ways to resolve conflicts, communicating more positively with her neighbors. We also discussed some events and people's approaches that can trigger anxiety for Jane. So we're kind of looking at maybe how to prevent some of this, right? And brainstorm ideas for calming techniques, what to do when we're feeling escalated or activated. And then what's our plan? So a good note, whether it's a DAP format, STOP format, or our own format, we should have a P in there. We should have a plan. And that will be that we'll meet twice weekly for 3 weeks to practice these calming techniques. We're going to review progress on the neighbor interactions. After 3 weeks, then we're going to meet to weekly. And if the client feels more stabilized and comfortable using those skills, that's when we'll make that transition. And then this is a result of this. Now she feels hopeful about the plan, and now she's going to be keeping her housing. And then she shared that the writer offered much support and encouragement to her. So hopefully this is a helpful example to see how it could look in our world to do this golden thread from start to end. Now here's just a very generic example of a service plan template. We're sharing this just in case you're starting from the very beginning and have never even written a service plan in this very structured way before. As you can see, this example, and this should be in our extranet file as well. It's just to capture some of the elements that we talked about being important, like the client's names, their goals, the desired results in the client's words. What are some of the resources around us that can support our ability to reach these goals, right? And then treatment recommendations, and then we're looking from a strengths-based approach. What are some of the strengths and abilities our client is going to be using to help us to get this done? And then you can see here we have it broken down by the objective, the actual intervention, the service type, could be you responsible or the client, and then the frequency. And then what's our target date? What day do we think this will be done? And I think Cheryl has some additional, more specific examples to share based on what some counties have been using or looking into creating for the services here for Medi-Cal.
Yes, let me pull up. So I just put 2 links to PDFs in the chat that are also included in the link to the session folder. So you'll have multiple ways to access these. But the first one I wanted to highlight, this is a fillable PDF form. So if your agency is using paper documents, you can use this. I would say if you already have a housing supports plan and you have a lot of staff and they're used to using that, it might be worth just seeing what elements are missing that you need to add and continuing with the same form, just keeping it easier for staff. And then maybe just, if you're using paper, highlighting it. If you're using an electronic format, just doing a training for staff to say these are the new elements you need to add. That's probably the simplest thing if you're already doing housing related individual service plans. If you're not yet, this template might be a nice one to use if you're doing paper, or you can add these fields into your case management system or HMIS. I've talked to some of the HMIS vendors like Clarity, BitFocus, and some others, and there are ways that you could, work with your COC or as an individual provider, upload a form or turn it into data elements to be entered that creates a digital service plan. So there's lots of options, but we wanted to give you a template. So if you're just starting, you don't have anything like this has all of the language that's used in CalAIM housing related community supports. So it's called a housing supports plan. It's meant to be individualized. We included the HMIS ID, but that's not required by the Department of Healthcare Services or managed care plans. This is an example that we used with a county where they were using their HMIS system to do some matching. So you'll see that HMIS ID number. It also includes the Medi-Cal member ID. So here, you can then fill in whatever the ID number is. This is a fillable form. You'll see there's a start and end date, and you'll want to make sure that that start and end date aligns with the authorized period for the services. So when you hear from the managed care plan, hey, this person was referred to us, we authorized them for services, here's the authorization start date, you'll want to make sure that your service plan aligns with that start date. You have the ability here to make revisions to the plan. So maybe when you start, someone has only one goal, they want to stay housed. And maybe as they're stabilizing in housing, there are other things you're realizing could be additional goals that are housing related that you could work with them on. So you can revise a service plan and include the revision date. In this example, this is to be updated every 180 days, and we included that in this template because that's what I'm seeing from most managed care plans, but not all. So again, if you're using this form or using your own existing form, talk to the managed care plan and ask if they would accept your existing form. And you may just need to add a few fields. We included the actual activities as checkboxes so that you are sure that you are providing services that are allowed. And in the contract, if you hold the housing navigation and transition or housing and tenancy sustaining services contracts with a managed care plan. So your service provider could then go through and actually check the boxes of what they plan to provide in the service plan. It just makes it a little easier to have check boxes. And then here, this is exactly what Ambrosia showed you, but just in fillable format. So there's a place for strengths, a place for identifying barriers, goals, action steps, and who's responsible. And then at the end of the plan, you'll see that there is a place for emergency contact information. If you are coordinating with an enhanced care management provider, to put that provider name and phone number. It's not required, so it's not highlighted. But what is required is the member's name, the staff name, and staff signature. Member signatures are not required by all managed care plans, and so that's something you'd want to check in on. So this is one of the templates we included. The other one I want to show that I put is the crisis plan. So some contracts and managed care plans are saying that the crisis plan could be included in your housing supports plan, and you might just have a section about we've identified these barriers that this individual might face for staying successfully housed, and here is what we'll do if they encounter a crisis. Others outline that there should be a separate crisis plan, so this is a template for that. So just, here's what it looks like when I'm doing well. These are things that cause me stress or might trigger. And then if those behaviors might impact my housing, this is what I want supporters to help me to do. And here's who my supporters should include. So the client, again, is getting to say before a crisis happens, who they want to help them through a crisis so that they can ensure they're staying housed. So I'm just going to scroll down through this and ask if there are any questions you might have. Again, this should look very similar. It's the same final piece around the client signature, not required, but optional if you want to be sure you're showing the client's involvement in it. All right, and I'll take us back to the PowerPoint now. Okay. All right, any questions about those templates? Okay, we're going to talk briefly about supervision, oversight, and support. So what you can do as an agency to support your staff in this learning curve. And I really am thankful that Terry gave that timeline because Um, Managed care plans are under a lot of pressure to roll things out. Providers are under a lot of pressure to find new funding sources that are sustainable. And everything feels like we needed to have it done yesterday. But this type of transition really does take time. And so there's a big role that supervisors can play in helping staff to learn new requirements and in hearing from the quality improvement staff. So if you have someone on staff that's doing quality reviews, looking at trends and figuring out what are some ways that you can support staff that feel supportive to them, and asking staff what feels supportive and what are the best ways that they'd want to learn and ways that they like to receive feedback. Just having honest conversations during supervision about that this is a transition and giving examples about the why the agency is transitioning to this, that this is a additional funding stream, that this can mean ideally, we want it to mean better care for clients. We want it to mean more sustainable funding for the agency. I think having those honest conversations can go a long way because no one got into this work because they want to write progress notes. At least I haven't met anyone yet. So, so case managers will need extra time and coaching to complete the new forms. And so if you have existing forms, like I said, intake forms, assessments, whatever has changed, there are going to need to be conversations and staff training about that. And then also this can be an opportunity for coaching around, like Terry said, improving client care. So what types of conversations are case managers having right now, and do they have the time to spend with each individual tenant to really understand what motivates them and what they enjoy and what their preferences are and what their values are and what things they don't care about, and how that can be incorporated into your progress notes, into your service plan and goals and objectives so that people really feel heard, and it can build the relationship for case managers with their clients. That supervision happening throughout the documentation process is really important. And so I think ensuring that your supervisors have an expectation in their job description and an understanding of what they can do to help in reviewing service plans for the purpose of supporting staff and ensuring good client care. That's a part of their job process and workflow. If it's not in their job descriptions right now, if it's not in their templates for what they talk about in supervision, these are things that you'll want to add. And then recognizing that that might mean more time for a supervisor. And if they're supervising 20 staff, how are they going to have time to meet with everyone and really give people dedicated time? So we've talked a lot about the opportunities for grant funding to cover new startup costs. The path cited grants can cover up to 18 months of staffing costs. So as you're thinking about all these new documentation responsibilities and the review time and the training time, there's an opportunity now to get some grant funding to help you in staffing in a way that you really can support folks for success. Okay, so some examples of things that supervisors can do during supervision. You can have group supervision with all of your case managers and do a sample case conference, or maybe wanting to review a progress note and the golden thread piece in a group supervision. That might help to if you depersonalize the note to be able to talk about trends and not cause one case manager to feel targeted or called out, but really an opportunity to talk about how can we make sure this is working for everyone on our team and that we have equitable expectations. This was something that, having people with lived experience on staff, it often this documentation learning curve, if people have not gone to college, have maybe got their GED or didn't finish college, some of the writing requirements and examples and even the language and words used feel very clinical and aren't how people might talk about the services they do. And so in supervision, this is an opportunity to talk about, tell me what you did today. Let's talk through how we can write that down, and you're ensuring that it's in the case managers or peers' words, but still meeting the medical necessity requirements, but not feeling like they're using a voice of a clinician or something that doesn't make sense to them. So this is a time to really talk about that, and you might need to build in longer times for your supervision at first, and more time for your supervisors to have directly with staff. So if you're wearing multiple hats, that's something to think about of, do you need support with supervision? Do you need support with some of the other hats you're wearing? Something's got to give. So what does that look like? And what does that mean for then other fundraising and the grant funding opportunities? When possible, add in fun. The last agency I worked for, we would have all sorts of staff challenges and parties and rewards for documentation being completed on time. We would do waffle parties and omelet parties and things that, when people were starting their day, that the quality review team would give reports. And it wasn't just for people that were doing excellent. So we had all sorts of different ways that we could incorporate fun into, we had time where at the end of the day, people could come back and write notes together. And we'd have pizza. So it's just a time for, you could have coaching available from QI staff or from supervisors as you're writing your notes. Get it done before you go home for the day, and you're not trying to cook dinner and write notes and watch your kids and do all of that at the same time. So there are some ways you can work this in, and again, thinking about how you can request funding through Path Cited to support documentation training and support in that learning curve. These are one-time opportunities in terms of some of this incentive funding. Okay, Terry will talk a bit more about training in a few slides from now, but just as you're thinking about your staff training and onboarding, documentation training in the first 2 weeks, you'll want to keep really simple. If staff haven't been providing services yet, they just need to know the basics of what's required of them in terms of timeliness, HIPAA compliance, and then you'll want to really build in that learning curve into your coaching. So you'll want to go through your policies and procedures around documentation early on, but understand that you might need a 6-month ramp up period to a full caseload if the documentation standards are Medi-Cal documentation standards, because it really takes time to get into the swing of how you write your progress notes. All right, I'm going to hand it over to Terry.
Thank you. I really appreciate that piece on supervision. As the program, I was actually supervising the program director who was supervising this staff, but I got very, very involved and hands-on into the supervision and moving staff along. And it really is a big piece of how, if it's going to be successful or not. So I really appreciate hearing that. I hope you all do too. One of the other things I did, in addition to all the great tidbits that Cheryl shared, is I did allow staff to vent, not all the time, but sometimes when we started our meetings, we talked about the challenges, especially because we were per unit. So that beginning and end time was so annoying to staff. And I allowed them to vent about it and complain about it. And then we moved on. But it did help that their voice was heard, and I heard them. And there were some things that in that feedback loop where I allowed them to talk about it, we did also make some changes that I think were really positive. And we were also very conservative when it came to the productivity piece and how much we thought we were going to bill. I worked really hard to advocate up to my supervisors and the executive team that we needed to start out slowly so that it could be successful for staff. And I didn't want anyone to be set up to fail right away. And we were very conservative in how much revenue we projected that Medicaid was going to provide for us. And in the end, we exceeded that, but I think it's because we did start out very conservatively and very slowly. So you want to build on successes that staff can have and not set people up to fail. So So thank you for that. I think supervision piece is really, really important. So we're going to talk about internal monitoring quickly, everyone's favorite subject. It's very awkward and uncomfortable. Everyone hates it. I was part of the internal monitoring and quality reviews at Volunteers of America and at the behavioral health agency I worked at before that. No one likes it, but what I say is very true. It's way better that we find our mistakes than an outside entity who is funding us finds our mistakes. We have to find our mistakes, we have to fix them, and we need to make sure that we are at the lowest risk possible for an external audit when they come along, when they do come along. So that's why they're really, really important. They are proactive, and you want to make sure that you have a plan and a process that works. And also never be afraid to change your process. I always say, in theory, something might sound like a really great idea, but then when you actually implement it, you realize you forgot this, or you really didn't need that. So don't be afraid to look back and say, oh, we didn't really need to do this monthly. We may be doing it quarterly is good enough, or we didn't really need to look at this piece of the chart, but we really do need to look at that. So make sure that you're constantly providing yourself that internal review to make sure that what you're doing is working. But having an internal monitoring process that you follow to find out where the deficiencies are or where your risk is in terms of the outside entity coming in is going to be really important. So here's what an internal chart review process might look like. Looking at timing and frequency, depending on how big your agency is, how many clients you have, so how many client charts you have, you may decide to do your charts monthly for a half a day. You may decide to do your chart review quarterly for a whole day. So it just depends on the amount of clients that you have. You can pick up certain percentage, 10%, 15%. I think in the beginning, if this is very new to you, you may want to review more charts. And then as you're getting more confident that you're doing things correctly and to get the billing that you want, then you can maybe get it less. But I would start out maybe doing more chart reviews than less chart reviews to make sure that you know how staff are doing. Designate specific staff, and you can rotate in specific staff. The progress note, what we call the technical elements, so that checklist that you either have or you don't have, the signature, the date, the goal, all of those things you can either check yes or no. Many different types of staff can do that. So you can have data entry staff do it or spread that job across different staff. When you're actually reviewing the quality of the progress note, all of those examples that Ambrosia gave in terms of the objective writing, and is it attached to the goal? Is the goal there? That type of quality review, you want to really assign very specific staff. So case manager to case manager, or maybe a higher level of staff reviewing case manager notes. But you want to make sure the person reviewing has a really clear understanding of what they're looking at and what they're looking for. Again, as the supervisor to our internal reviews, I was really hands-on in the beginning because we were so new and progress notes were, we had a long way to go in getting to those examples that Ambrosia gave you. So I was pretty hands-on in the early stages. So you need to decide yourself, but the important thing is following the process that you are creating and reviewing the process. If it doesn't work, then change it. There's also different types of reviews. What we also did, because again, we were a per unit billing, we targeted every quarter the highest utilizers of the billing. And the Department of Medicaid told us that they were going to look at our high utilizers. So it wasn't a big secret as to why we did that. So we targeted those every quarter. We looked at the billing and we compared it to the notes. So if we in that quarter billed for 50 minutes, we billed more than that, but just to be easy, 50 minutes, we looked at the progress notes to make sure there were 50 minutes of progress of service interventions that were done for that client for that quarter. So just that billing. Then we looked at that person in terms of justifying the time spent. You know, I remember one specific time we had hours and hours for a particular client. I was a little nervous, but when I read their notes, they were suicidal and police were called, and it was very, very clear in the notes why so much time was spent with that particular client. So just making sure that that's clear. And correcting mistakes is really important. Again, the reason you do internal monitoring is to lower your risk as much as possible to the external audit. And when you see those risks, you want to make sure that you find out why. So is there a trend that all service plans are late or no service plans have objectives or timelines? Figure out why that is, and then you can correct it. So correcting is important, but you want to correct the past and you want to prevent it from going future too. So you want to find out why it is, not to point fingers or get people in trouble. Although if you have to have a corrective action plan, you have to have a corrective action plan. But specifically, what you're doing is you're lowering your risk. So if you find out why this particular thing was deficient or not happening the way it was supposed to, then you can correct it and you can change it from continuing to make that same mistake. Documentation training, I think Cheryl already talked about this a little bit. It's important that we have it set up for staff. I know there's a lot of staff turnover, and so many times when new case managers start, we just throw them in. And because everyone has been working overtime, taking care of everybody else's clients and filling in for that vacant position, but we really need to try not to do that to new staff. We want them to have good experiences from the beginning. So you want to set up their training plan based on what it will work for them. What experience do they have? Do they have experience with documenting and with Medicaid? And then base how you set up your supervision and training based on their experience and what they need, and make sure that it's individualized, just like we want our client service to be individualized. We want supervision to be individualized as well with our staff. And one of the things that we did, you can go to the next slide. Yeah, one of the things that we did at Volunteers in America, which was helpful for us, is our HR department voluntarily offered to help our family service program with this, because we had local and state and two-state Medicaid and Division of Mental Health requirements for training. So they got all of the training requirements in a spreadsheet, what was needed in 90 days, what was needed in 30, what was needed in 6 months, and they got all our staff and their hire dates. And they sent to the family service director when everybody was due for what, and it was really, really helpful. So any kind of that internal collaboration you can do between your departments would be really important too. So these are just some suggestions, some recommendations for you in terms of what you can do in that first month. Doesn't have to be the first month. Whatever you do, please follow it. Don't have a policy that you don't follow. Make sure that you follow it, and make sure that it's really helpful to new staff as they're coming in, and it fits their experience and what they need. And you can see the documentation is important in that first 90 days, but all of these activities are equally as important in those first 90 days. Okay, sorry I went through that really quickly. So if there's any questions, let us know.
Thanks, Terry. I do want to add that some of the managed care plans offer trainings as well.
Oh, great.
So it's worth reaching out if you are in the process of getting a contract or exploring getting a contract, or if you already have it, but you're not sure what the managed care plan is offering. I know some do offer trainings on HIPAA. Some talk about the client grievance process requirements and provide training on that or on quality improvement. So it's worth seeing what you can leverage there. And then, yeah, there are other provider agencies that have been working within Medi-Cal for a long time and may have trainings that you can send staff to if they are related enough. So there are ways that we might be able to share
Yeah,
share the
great, good point.
training.
Yep.
Yeah, share the training burden with the provider partners in your community is going to be important. Okay, I think we are on our
Couple more.
our last little piece. So we have talked in several sessions about quality improvement best practices, and I just want to highlight that if you do not yet have a quality improvement plan or a staff person set up to do this, for your documentation, at a minimum, you'll want to be doing these internal reviews and the corrective actions based on that, because some of these requirements are related to the federal Medicaid requirements around what is included in a progress note, and others are listed as requirements so that you have the data to share with the managed care plan that is within your contract, what they are expecting that you'll share back with them about services provided, the activities, when someone is housed. So that should all be added to your quality improvement plan if you have one, in terms of processes and workflow. And if you don't yet, this is an opportunity to look back at our session 8 and then the session that was session 7 on managed care plan compliance and session 8 on policies and procedures, and think what do you need to take from some of those templates to work through as an agency what you need to add in terms of quality assurance and ongoing improvement. Okay. We're at the end here. I want to highlight a few documents that may be new for you. So because Medicaid, and in California it's called Medi-Cal, the Medi-Cal program is funded, 50% is paid for by the federal government, and then the other 50% is paid for by the state. Those state dollars then go down to managed care plans. So managed care plans might have their own compliance regulations, but it's less often that we get to see, where is it actually in the federal government code of regulations that these things are required. And so I included 2 links here in the read section that are from the Code of Federal Regulations about Medicaid documentation that talk about case management services. The one link talks specifically about what needs to be included in a progress note, and the other link is what needs to be included in an assessment. So if you already have these progress notes and assessments, but you're new to Medi-Cal, you're new to Medicaid, these might be a nice checklist place to start to say, what are the elements that we absolutely have to add? Okay, we already say which staff member provides the service. We already include the client name, but we don't have a signature. And now we need to add a signature field and figure out, how do you do that on an electronic record? And there are multiple things that are accepted. So you could have a signature pad, a digital signature, or an electronic signature that's just the person's name with the date. Both are accepted federally. Both are accepted at the state level, but you might need to add a policy saying that this is how your agency will do it. On the Explore section, that is the link to the folder for session 9. So that includes the 2 things that I showed, the housing supports plan and the crisis plan. It also includes an assessment that we created for a county here in California that was looking to have some sort of assessment for how to demonstrate the need to reauthorize tenancy sustaining services. So I'm going to take a moment and pull that up just so that you can see what is in the folder there and get a sample of this assessment plan. We developed this in coordination with a COC that is also partnering with their county. And so this is, if you don't right now have an assessment that has been approved by a managed care plan to demonstrate that why are ongoing tenancy sustaining services medically necessary for this client, There are questions here related to housing stability that your case manager can mark as true or false. And these are the types of questions that then can help you to justify why services are needed in an ongoing way. So if someone has missed a rental payment in the last 12 months, or so really you're saying if they have met all of these criteria for housing stability, they've demonstrated that they can remain stably housed, they have no lease violations, they have no missed rental payments, they don't have any utilities in arrears, and there are no disruptions. You can go through this list. If everything is marked true, then it may be difficult to justify why the person needs ongoing services. The reality, though, is for serving people who are living in permanent supportive housing and many of the people who meet the eligibility criteria for housing and tenancy sustaining services, they have complex needs and they have multiple chronic health conditions. And so there will likely be some of these boxes that you will check as false. They may not yet have the ability to independently navigate and complete all the forms for related to ongoing housing stability. So maybe that's false. They may right now not independently seek out connections in the community and they might need your help with that. So maybe that's false. This form then allows, it tabulates the number of checked boxes of true or false. So there are questions related to independent living activities and if they need help right now with cleaning or budgeting. Have they required help that's, after traditional business hours due to a crisis? So the case manager can go through this, check the boxes, and then at the end, it gives you a total score. And it allows for the case manager to provide rationale. So it says, if they have 16 or more checked as true, then maybe this person is really stabilized and doesn't need these services anymore. But if they don't, there's a chance that this provides an easy rationale for your case manager to say the services need to be ongoing, and then the case manager can say which of these, so the tenant does in fact have late rent payments that are now in arrears, and how you will then support this tenant. So this can be used both as an assessment and then turned into your service plan. So it's one more template that you can use if you'd like, if you don't have something for reauthorization, or if you're struggling, you're a year into your tenancy sustaining services and you're having to communicate the why there's a need for ongoing services. This might be something you'd want to adapt, or let me know if you'd like the Word version of this and you only want to take a part of it. We're happy to share that with you too. Our next training session is going to be on May 17th. So we do have a TA session scheduled for May 10th. That is, if you have specific questions for your agency, you want to take a look and share a policy or procedure draft you're working on, or you want us to review your service plan document or anything related to documentation, policies, or procedures, that is a session that is open next week from 1 to 3 p.m. And that's available for anyone who wants that technical assistance in a group setting. The next Medi-Cal Academy training is on May 17th, so in 2 weeks, and it's on the electronic health record documentation. And we'll go through all of the data elements that the Department of Healthcare Services is requiring that providers share with managed care plans, or that managed care plans collect from providers, so that you're sure to have an understanding of what you might need to add to your case management software or your HMIS or your electronic health record, depending on what you're using right now.
Sure, I just wanted to make mention that I know this can be overwhelming, and you all have probably mentioned this already, but it's really important to have a plan with steps so you don't get overwhelmed. And remember that it is a step-by-step process that can be tweaked and revised along the way. And the more support you have from your entire agency, the better, of course. But don't let it overwhelm you. It's a step-by-step process.
Yes, thank you. Thank you, Cecilia. I hope you all have a great rest of your afternoon. Thank you, Terry. Thank you, Ambrosia. Thank you for leading us through this. Really appreciate you both. Okay. With that, we'll sign off. Take care, everyone. Glad it was helpful.
Bye, everyone.
Bye.
Nice to be here.
Take care.